Today, we'll be hearing from Dr. Claire Trescott. She's a practicing physician and the former primary care medical director for Group Health Cooperative in Washington State. Recently, she was appointed to the State of Washington's Medical Quality Assurance Commission. She's an HCIM Senior Strategic Advisor and a member of the HCIM Healthcare Strategic Advisory Council. Now, for more on the value of integrating healthcare, here's Dr. Trescott.
We recently attended a national conference and discussed value-based healthcare, what's working today, what isn't working, where can we go from here. I'd like to talk about a slice of that conversation about how are we coming together in integrated systems to produce more value-based healthcare. So let's start with talking about what's working today. If we look at historically where we've been, clinical teams have been doing the work of healthcare, providing the care, but relying on insurance companies for data. The claims data is where we've been deciding, has the product been successful? Is there high quality? Is there value? In other words, how well our diabetics are doing is discovered from claims-based data. It has not come from the clinical teams. And prior to the advent of the EMR, it was technically impossible. However, what we're seeing today is that providers with an EMR, as it becomes more and more functional, can now get their outcome data directly from clinical records and no longer need to go through claims data. This is allowing them to come together in provider groups in new and creative ways and to demonstrate their value in new and creative ways. We continue to need insurance company or payer-provided medical management to be involved in care, but it is gradually being replaced by high-functioning medical homes. What these do is create continuous healing relationships, and when we bring a number of primary care sites together, we see them become clinically integrated networks. And on the specialty side of the equation, we see integrated practice units. Integrated practice units are specialty groups that come together around dedicated clinical situations. Things like back care or cancer. You bring together specialists that all contribute to care of these patients, and they work in an integrated fashion. We're beginning to see signs of insurers integrating differently with clinical teams. We'll see an insurance company placing their care managers into outpatient offices of physicians. This happened at Geisinger, where they took their case management nurses and had them spend a day or two in rural outpatient primary care offices and become part of the primary care teams. They demonstrated an increase in quality in those offices that was measurable and significant. Payers will continue to have a vital role in healthcare. We continue to need their skills and knowledge in running the business of healthcare. We have examples nationally of integrated systems that have succeeded in integrating both disciplines for decades. These have worked, but creative tensions exist even to this day. Working within the group health and Kaiser Permanente systems, it is evident that challenges pop up between the health plan and the providers. These are expected based on the conflicting issues between high-quality care and cost-effective business approaches. Successful groups have solved this by starting with leadership agreements that put the enterprise above individual needs. An example of this occurred in Health Partners in Minneapolis, where the internal ENT group had a higher cost approach to tympanoplasty than a community group. The leaders of the delivery system and the health plan came together and agreed to make the outside group the preferred provider. That is an incredibly difficult decision when the internal group are all salaried employees of the same system. However, it worked out in the end as the internal group changed their practice to become competitive and returned to preferred provider status. This only worked because the leaders had taken the time in the beginning to have clear agreements. They had agreed that when these problems arise, they will try to put the enterprise above any individual division. As we move to new structures within healthcare, there are some tactical approaches that are proving to be successful. Value stream mapping is particularly helpful to use as a starting point. In this exercise, the leaders of the health plan and the delivery system come together and map out the experience of the patients from the day they purchase the insurance through utilizing clinical services and then receiving a claim. Patient-centered value is identified every step of the way, and waste is quickly identified. It's important that both financial reality and clinical reality is included every step of the way. This exercise is done by leaders as they bring in knowledge of external forces and customer needs. This mapping will produce a new, streamlined structure that can then be operationalized. The new concepts are taken to middle managers and frontline staff to design the actual processes that will make this come to life. As they design new work processes, they will be developing skills that will help them to continuously evolve the system going forward. We discovered that this was essential in taking a large healthcare system from paper records to an electronic medical record. All the old workflows needed to be changed. It also became evident that clinical offices must develop more teamwork. This move to team-based healthcare had already occurred in operating rooms, emergency rooms, and intensive care units, but not in outpatient offices. As we've already discussed, differences continue within any integrated system. Working through the conflicts often produce new and creative solutions. We talked about PCP managing care coordination versus off-site nurses managing it, and Geisinger's solution. Each region will work out individual approaches that fit their needs. A major issue for us in healthcare redesign is breaking through the traditional silos we have created educationally. Nursing roles versus MA versus physician versus social work, etc. The boundaries need to be much more fluid in order to create high-functioning teams. We need to understand and share the roles of our coworkers in order to do effective healthcare. Medical schools and nursing program leaders understand this and are now bringing students together early in their education so they can learn their craft in a team-based setting. We have not yet sorted out the financial sharing of resources between PCPs and specialists. Fee-for-service reimbursement has rewarded procedure-based work much more than cognitive expertise. Value-based payments should even the playing field over time. We're also seeing this sort out as we look at bundled payments and other new financial approaches. The initial medical home was built in pediatrics in the 1960s and attempted to highlight relationship-based healthcare. The premise was that the most powerful tool we have for healing patients and improving health is the interpersonal relationship between the provider and the patient. This relationship, strengthened over time, produces the trust that is required within effective care management. The development of the electronic medical record, email, virtual medicine, and other new processes has made the medical home a living, breathing reality. We can now produce continuous healing relationships that give the continuity and insight required for effective care. A patient can email their physician at 2 in the morning with a question and get an answer the next day from a team of people they know and trust. This is true patient-centered care. These advances are powerful tools in providing better, more cost-effective care in the future.